She's not sick or anything like that. She just is needy. And we are waiting for Dr. Spillane, and if I'm mispronouncing her name, then I apologize. But she is the clinician for the case today. As we're waiting, let's just quickly do housekeeping, which we always do. And these sessions are recorded. The recordings are shared with Dr. Foster to post on our YouTube channel or whatever it is. So if there is something for a future service or something like that, and you want to go back and listen to it, they should be available. I think we might already have a volunteer for September's rounds. I need to double check with the clinician. She had actually volunteered for today's rounds, but then she realized it was her birthday, and so she did not want to do anything academic on her birthday. That is Dr. Shropshire. So I think it was funny that she did not remember what her birthday was. So as long as she's ready to go in September. Ooh, I might be out of town. Okay, we'll figure out September's. Then if you notice you've been knocked off, you haven't been invited in a couple of weeks or a couple of sessions, make sure you reach out to me because sometimes Outlook knocks you off the list and it's not my fault. If there are other people that you think might be interested, I try my best to make sure that any requests get immediately added to the distribution list. So even if you've requested and I haven't added them, that might be my fault. Don't feel bad about nudging me multiple times. I'm very happy to add people to the list for distribution. And I know that sometimes, especially for the path part, a couple of people might be there, and then other people will be joining kind of from multiple people at one computer so that they can all watch the together, which is fine. I have no problem with any of it. So okay. So today's case, still not seeing her on. I will make sure I'm going to send an email really quick while we Mary, can you be in charge of letting people in if you can?
Yep.
Oops. Sending a message in all caps is not a good idea. I can talk about it because I already have it brought up, so it's not that big of a deal if she isn't able to join in for a few moments. But I already have it kind of launched in my settings. So I will give the basics for the interest of time. And if you have any questions or any concerns, please feel free to ask questions in the chat. Dr. Nabity will be able to make sure that the chat is being followed. Or raise your hand either way. I probably am gonna pop quiz people because I think that's more interactive and I think it keeps kind of people on their toes. I won't be offended if you have the wrong answer. I'm never actually keeping score. And if you are super busy, something happens, you walked out of your office or something like that, just let us, it's not going to be that big of a deal. Like, nobody get worried about it, please. Okay, I'm going to be able to share my screen. So the dog that we're going to discuss today is, and I'm not sharing anything yet, so don't worry, but the patient's name is Honey. And it is a fairly young female intact, a golden retriever that is located in California. So the information that we received at the time of biopsy in July was that the dog had juvenile onset chronic kidney disease. And just so you guys know, that is the term that we are mostly, I think, did I see every, oh, no, I'm not seeing every. The term that we like to use now for juvenile nephropathy, which is kind of a lot of overuse in the literature, is juvenile onset CKD. It actually is much more descriptive for what we're talking about. So this could be for many etiologies. It does not have to be from specifically a maldevelopment issue, but it would be a scenario where the dog. I think we kind of chose the 3-year discussion point mostly at random for the cutoff. But any dog that's under that age group that has a stageable CKD. So let's say you had a patient that was a year old and had an ethylene glycol exposure, so that had an AKI. If they survived the AKI event and they had renal scarring and eventually then became either azotemic or had evidence on ultrasound of abnormal kidney shape and scarring tissue, that would still technically be a juvenile onset CKD once they got to the scar plateau stage. But a lot of times it's going to be patients that have evidence of abnormal development. So that's often what we're talking about. And then the other term that we tend not to use these days as well is we don't use it nearly as much as we used to, is renal dysplasia. We had a lot of commentary from clinicians that was about the overuse of that term by radiologists mostly. And so if the radiologists were doing an ultrasound and it was a young patient and the kidney was slightly abnormal shape, or maybe it's too small or something like that, it would just go down as a dysplasia case. And so again, what if it was one of those ones that had an infection during its child, like during the neonatal period, or had a toxicity during the neonatal period, or had, or even, during the first year of age as the animal's growing. Let's say the animal has to have a nephrectomy because of a trauma incident, and so now it's functioning on one kidney. Technically, we can put them as a stage 1 CKD, and therefore they are a juvenile onset CKD, but they are not a dysplastic CKD. So I hope all that kind of makes sense. If you guys have any questions about why we use the terms the way we do, please let me know. But the term we like is juvenile onset chronic kidney disease. And so that's what this dog had. And it was diagnosed, let's see, and I'm not showing you guys anything, so don't worry. I think it had been diagnosed for a few months. And so it was already at stage 3. So the serum creatinine was already at 2.8 at the time of diagnosis. Or at least at the time of biopsy. So she went to her primary care physician, primary care veterinarian, excuse me, in early March, and she went because she was having a bout of diarrhea, some degree of plaquuria, and she had urinated indoors. She had been in estrus and she'd been wearing a diaper, so they weren't really sure if maybe she was also leaking urine during that time. So because she had the diarrhea and she was having abnormal patterns of urine, they did blood work. They on March 1st, 2024, they diagnosed or they found that the serum creatinine was 2.2 and the SDMA was 20. They did see evidence of a bacterial UTI based on white blood cells in the urine, a low specific gravity, 2+ blood, and they also saw many rod-shaped bacteria. They cultured it. It was positive for E. coli, and it was a sensitive E. coli, so for any antibiotics tested. And then also it had a positive fecal test for Giardia. The other tests that they looked at were parvovirus and lepto, and those were negative. She was treated appropriately for her UTI, and her diarrhea and the UTI went away, but her azotemia was still there. So again, this could definitely falls into juvenile onset chronic kidney disease. Is this serum creatinine due to scarring because it had a previous UTI and maybe even pyelonephritis? It's possible. So we really need the biopsy to tell us what's going on with the renal parenchyma, even though the clinical syndrome still falls under juvenile onset CKD. So then they she was able to culture negative, and that was even like within 1 week or 2 weeks of antibiotic therapy. But her serum creatinine had actually increased from 2.2 to 2.9. They did an ultrasound and she did not have a left kidney. So she was born with one kidney. So already she falls into that category of something was wrong with development of the kidney, or of the urinary tract, I guess I should say. So then her left kidney was absent. On ultrasound, she had an enlarged right kidney, which makes sense. She had to have compensatory hypertrophy. And it even had severely altered parenchyma and had mild pylectasia. So then they kept rechecking blood work, and her serum creatinine kind of maintained at 2.9. By the time they decided to refer for biopsy at the practice, at the tertiary care practice. So in July, they decided to go ahead and do the biopsy. And by then, the serum creatinine was still pretty stable at kind of the 2.8, 2.9 range. The dog was not proteinuric. The UPC was 0.1. Was not hypoalbuminemic. The albumin was 3.3, and the dog was not hypertensive. Blood pressure at 150. So let's see. I'm gonna see who all is here. Okay, and she has not been able to get back to me. I hope everything's okay. I did email her to see if she was gonna be able to join. So make sure I actually emailed the right person. Yeah, I did. Okay, that's always the possibility. Okay, so clinic-wise, we know we have a single functioning kidney. This is actually an open question for clinicians because I don't know how you guys treat this. So the clinicians on here, if somebody wouldn't speak up, what are any concerns you have for biopsying a dog that has a single kidney, and any kind of preventative steps you might take for making sure that that one kidney remains somewhat healthy? Has anybody here biopsied an animal that only has one kidney? Everybody is on mute if somebody's trying to talk. Dr. Skinner, Dr. Inman, you haven't biopsied. I'm just curious. There's not a yes or no question. I just don't know who's biopsied a single kidney person or single kidney dog.
I have not.
Okay.
Not here.
Okay. So, I mean, it makes sense you would be worried, like it's the only functioning kidney and you don't want to do too much damage to the kidney that is doing all of the work. So there is a little bit more caution when you go in for that biopsy. From a practiced, well-versed nephrologist who's done a lot of biopsies, these are usually that traumatic when we take a needle core biopsy or a small wedge. So as long as you've done a few of them and have some practice, I don't imagine that you would do so, like you would ruin the only kidney that's available. If it's your first biopsy ever, it probably is not a good case selection to start on. We do biopsies on single kidney patients and humans all the time. We do kidney biopsies on single patient pediatrics all the time as well. So it's not, again, something that should be taken lightly, but it's very, very commonly done in the human scenario. Single kidneys in cats, obviously, probably even more scary. But we do get biopsies from transplant patients, so it's their grafted kidney, and that's all they have functioning, and they have a biopsy of the grafted kidney. So it is done. I just don't know. Having some experience kind of makes you feel a little more confident when you go into it. The other question, yeah.
From like a, I don't know, from like a functional unit perspective, I guess I think about like a single kidney that's functioning pretty well, you might still have like more issue than two poorly functioning kidneys. So it seems like scary to me in that way. That even if they just have one kidney, we're not taking that much of it with biopsy.
Yeah. You're right. And so as long as, I mean, in this particular case, we have a little bit of concern that even the right kidney is not the right shape. But I mean, you're not going to have hopefully most people are going to have an ultrasound before they biopsy or have an ultrasound at the time of biopsy. Way back in the day, Dr. Lees used to talk about people would just hold cat kidneys in place and just go ahead and stick a needle in them. And that scares me, but hopefully you'll at least have some perspective of how much scar there might be in the remaining kidney. But yeah, if it's functioning, I mean, we would hope that it would be amenable to getting that biopsy. And usually you guys are taking 20 glomeruli at most. Sometimes for the wedges, like I think this one was a wedge biopsy that they did, and so they got like 50 glomeruli. But overall, it's not, it is a small proportion for the number of glomeruli that kidney has. And so that's kind of the next question, or I guess the next point is that when we are looking at renal parenchyma from a suspected or possible renal maldevelopment case, we recommend to the clinicians, if they can, to take a wedge biopsy. And so obviously that's so much more invasive, and we totally understand. Sorry, and Jessica is asking a question right now, but so we recommend that you at least have a little bit more control over the procedure. So if there is bleeding, you're already internally in there, so you can stop bleeding. So a wedge biopsy is a little more helpful. The reason it's helpful is because of the type of disease we're trying to rule in / rule out. The type of disease that we're concerned about is dysplasia / maldevelopment / abnormal development. And it's very regional as a process. So trying to get a sample that has that region is the goal when we're trying to get the biopsy prepared. Jessica, what did you ask on your question? Can you speak or no? She said she did text me and say her computer was having problems, but let's see what the chat says. Would you have avoided a wedge biopsy? I honestly still think a wedge biopsy is important because I think if you go through, so Jessica's question was, the wedge biopsy in a single kidney case, is that a problem? Because you're now taking a few more glomeruli than you would be with a needle core biopsy. But the goal is the diagnosis, right? So it would be unfortunate if you took a needle core biopsy and you missed the area that had the lesions we're looking for. And I would consider that to be an unsuccessful biopsy because now you don't have the diagnosis. Okay. That's my dog. Okay. So while we're waiting here, I'm going to go ahead and, no, while we're waiting here, I'm going to go ahead and show you guys the pathology. And I do apologize for the hodgepodge nature of this, but that's just what's going to happen. When, okay, hold on. Oh, it's because I signed it a different way. Ugh. Later, see if that works. All right, let's see. Let me make sure if this works. If not, it's going to get mad at me, and I can just show you the report then. Screen. Are you guys seeing a screen that has my settings open? And now you're seeing a screen of the biopsy?
Yep, we see the biopsies.
Okay, perfect. So, okay, so you can see here we have a wedge. They submit one wedge and then we bisect it when it comes into our lab because it's usually a cube of tissue. So in order to get as much surface area for evaluation as possible, we're going to go ahead and bisect it. The sample that's over to the right is our positive control tissue, and so I think it's tongue or something. So it's just a really good way for us to look at what a normal trichrome stain or what this batch of trichrome stain should look like. So if that was really, really pale or discolored, then we would know that it was a batch problem and not a problem with our personal parenchyma or our renal parenchyma of the view. So that's the trichrome, but let me go to H&E. Hopefully it's still there. Okay. So again, we have the two samples that have been bisected. And I hope everybody kind of took into the fact that I had mentioned that the type of disease we're interested in diagnosing is fairly regional in the kidney. And I hope that's exemplified even on this kind of eagle eye view. So, you can see that we have a stripe or a radiating band. Mary, are you able to see my arrow?
Yes.
Okay. So you have a radiating band that has the type of process that we're interested in, but then you have areas that are somewhat more normal. They have fairly normal cortical tubules. And so let's say, as we were talking about missing the lesion, let's say you had a needle core and you only tracked right where my arrow is going, and I could probably even draw a line. So what if you had only, okay, sure. What if your needle had only gone that way? You would have only captured normal cortex. And so a wedge is going to give you more opportunity to get more surface area, more volume even of the kidney, so that that way you can make sure that you, or have a better probability of obtaining the area of interest. And this is one of those lesions that is regional / focal. And for the pathologist in the room, when I say focal, ooh, I do have pathologists here. I know. Kate Sarkin, Dr. Sarkin. When we say focal in the kidney, why is it a little bit different than saying focal, let's say, with a tumor? Can you mute yourself if you're available? Oh, we're just like gangbusters here. Nothing's happening. Okay, Peter, I see you. You're at least looking at your screen. Why is kidney focality different than, let's say, if you have a focal tumor? What's the difference between using the word focal when you're talking about kidney?
Is it like how we use different words like diffuse and global? Like, is it talking about the specific glomerulus?
It's talking about the percentage of kidney. So if you have if you have less than 50% of the kidney affected, it's considered to be a focal process. Now that might be that this area over here, which is only 10%, is affected, and then the other pole has a 10% affected area. So total you have 20%. There are two foci, but it's still less than 50%. So the word focal is very different in nephropathology than any other than when we use focal when we're talking about, I don't know, like having a splenic mass. If you have a focal splenic mass, that means it's just a single mass. If you have two splenic masses, we now have multifocal splenic masses. So the word changes its definition when we come to kidney pathology. And I apologize for that, but that's just the way it is. And so I have to keep reintroducing that concept every time. And so this type of disease process is something that can be quite focal. Thank you for contributing. And I apologize, Kate. I'm sorry your mic isn't working. If I ask you another question, you can put the answer in the chat. Okay. So and I see Dr. Lynn is on here too, so I can quiz Dr. Lynn. Actually, Dr. Lynn, or at least you were on here. Let's make sure you're still there.
Hi.
You there? Hi. How would you, what term would you use for the glomeruli in this area?
I can't see. I just see your meeting. Oh, they're hypercellular.
Okay.
And there is a cystic dilation of Bowman's capsule, so it looks like almost like cystic atrophy. There's some segmental collapse.
I like all of those things, and so I'm going to outline them for the people that are watching. So the dilation of Bowman's capsule is quite striking in this field. So you see you have this huge like little space, and this is Bowman's space. It's filled with a little bit of filtrate, and then a little tiny kind of compressed glomerular tuft. Now, Dr. And I'm gonna go, maybe let me go to the PS. I'm gonna get you to commit. Do you think this is too many cells, or do you think the cells are just squished together because of the collapse whenever it decides to resolve its focus? So the question is, do we think that there's proliferation and way too many cells in the glomerulus, or do we think that the cells, it looks hypercellular because the whole thing is kind of squished down and all the cells get pushed closer to one another? What do you think, Dr. Lynn?
I think it's because it's squished. The podocytes
Okay.
even look bigger too. They look hypertrophied.
Yeah, they're much more noticeable. Yeah. And there's probably a component of both. Like maybe we have too many cells in this one particular capillary lumen, but a lot of it is that if this were the full perfused glomerulus, everything would be kind of stretched out. And so the nuclei wouldn't necessarily be as close to one another as they appear here. So it is definitely a mix, but it isn't just a proliferative pattern that would make us concerned that there's a lot of inflammatory cell recruitment to this glomerulus. So just basically saying, like, we're not thinking that there's immune complexes that are attracting a whole bunch of inflammatory cells or a whole bunch of leukocytes. We think that maybe the mesangial cells are maybe undergoing a little bit of proliferation. The podocytes look a little angry, so they're a little more prominent. And we have a little bit of a squished tuft. And hopefully you guys can even see the wrinkling of the capillary loops as I outline them here. Again, because it's just shrunken down, exactly like Dr. Lynn said. Oftentimes we'll use the term that this is an ischemic atrophy. So whatever perfusion is coming from this tiny little arteriole to go into this tuft is not sufficient to keep it well dilated and keep its capillaries open. And then whatever is getting through these capillaries and is being filtered into Bowman space, it's basically being trapped and it's not able to leave Bowman space. And so we see up here, we don't really have a good connection to the proximal tubule. Now, remember, these are globoid structures, so it's very possible that the connection to the proximal tubule would be in or further out of the plane of section. But if we kind of look at a lot of them, we really don't see any that have very good connections to proximal tubule. And then one other thing is that there's a little bit of, again, as much as the podocytes over here are hypertrophied and a little more prominent, there is also more prominence of the parietal epithelial cells. Again, something is just basically, these are stressed cells, they're enlarged, and they are not their normal kind of morphology. Oops, I didn't mean to go that far away.
Hey, Rachel. Peter, I don't know if you want to ask it directly, but there was a comment in the chat or a question about counting quadrants.
Quadrants, what do you mean? Sorry.
Thank you.
Good.
I was thinking, or I've been told by some pathologists that if you're kind of debating about hypercellularity, you can like draw 4 quadrants on a glomerulus, and then you should get to about 100 total. I wasn't sure if
100
that was
total, 100 total cells in the glomerulus.
Yes, I think is.
It's not something I've done before.
Okay.
I usually look at the mesangial zones and make sure I have 2 to 3 cells. And then I look at capillary lumens, again, mostly focusing on the peripheral portion of the capillaries. That might be something that probably is a little bit easier to do in like rodent glomeruli for experimental versions of glomerular injury, because all the glomeruli are the same size, hopefully. And if you're actually needing like an active number, but with the variety of size of glomeruli we can get in dogs and the variety of size we can get even in humans, like obese humans have bigger glomeruli than non-obese humans. Pregnant women get huge glomeruli and then they get shrunken back down. So I think it would be a little bit more variable in that, but rodents should be a little more sustained as far as size. So maybe it would be something you could do experimentally.
It came from a rodent pathologist, so
that makes sense. That makes sense.
Perfect.
This little podocyte's probably dying here. He's probably falling off. Okay. Did you see anything else in that field? Which I'm going to go to try to find what I'm looking for again. Dr. Lynn. Oh my gosh. Cannoli, you are the most pampered pet of the whole planet. Why are you whimpering now? She doesn't like it when I'm talking and I'm not talking to her.
It almost sounded like you were calling me cannoli.
Oh my god. No, maybe actually it's probably because they're better up here. Okay, so what do you think about these glomeruli here, Dr. Lynn? I'm going to keep calling on you.
That's fine. They look a lot smaller than normal, and they seem to be just a little bit more abnormal in general. They almost look like fetal glomeruli or some sort of abnormal formation of a glomerulus.
Okay, perfect. So they're much smaller than our. Let's get our baseline for what a kind of a normal tuft would be. And actually, it's really not that many. Maybe this guy even looks a little big, but he would be what we would consider to be a fairly normal glomerulus. I'm going to go to okay, so usually when I get to this mag, I should be able to fit the whole glomerular tuft in my 40X on my particular computer screen. I'm not saying in general, like if you're looking at a microscope, you should definitely get a glomerulus in 40X. But in the size of my computer screen, when I'm at 40X, I should be able to fit the entire tuft in. And this one's not, it's barely like out of frame. So it's a little big for a glomerulus, but that's what we expect to see. So then if we go back to where I was before, and we go to the same size, you could probably fit 5 or 10 of these glomeruli in that same size. Again, they look very hypercellular. And the reason they look really hypercellular is they don't have very good capillary lumens. And so if you think about the phases of glomerular development, they basically start as a meshwork where like the endothelial cells are like growing into where the podocyte receptor, whatever is going to become the podocyte cell, they kind of make this meshwork together. And originally they become just a coagulum of cells that does not have a good capillary lumen. And so as they mature, they go through like a comma phase where they start to look like, well, this is the glomerulus and the proximal tubule part, but they kind of like a little bulb, and then they have a little bit of a branch off of it. And then as the glomerulus gets older, they should start to make actually capillary lumens. And so we might have a capillary lumen here and a capillary lumen here, but basically those are the only 2 capillaries that got made in this entire glomerulus, and it just stopped growing. So think about, if you think about like arrest lines when you're talking about a skeleton, something stressed this kidney out during this time of glomerular maturation, and all the glomeruli at that stage were trying to develop their capillaries just said, I almost said a bad word. They just said, give it up. I'm just going to go ahead and just stay in this tiny little meshwork of collagen and cells, but not actually make a good capillary bed. And the fetal glomeruli that we like to see, there really aren't that, oh, maybe this one. We like to see for fetal glomeruli really good, that's actually probably more of a sclerotic one, but this is the prominent podocytes is much more indicative of the true fetal nature if you look in the textbook. But even if they don't have that prominent podocyte, but they have the lack of glomerular capillaries, I say that they have an immature morphology. You still have a Bowman's capsule in these glomeruli, even though they're not really doing good capillary development, they'll still have a Bowman's capsule. And they'll still have their little arterial pole, but they just are not, they've kind of given up the ghost as they were developing. Okay, so then that's one feature of this lesion. And I know I'm really honestly just dragging out the pathology, but hey, that's what we're here for, it's pathology rounds. Dr. Hokamp, you've dubbed yourself I know you said your microphone isn't working, but you can put it in the chat. What is absent in this region that is present in this region? I'm going to throw you a bone for an easy question.
Okay, so I've got 2.
Oh, now you have
Yeah,
voice.
well, it's a situation. We've got a couple of computers going here, so I was trying to keep from doing the
doing that.
woo, 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 woo.
Yeah. Okay, well, if you can talk,
I'm also
that's
in
great.
service, so go ahead. Ask me
So
questions.
we have this kind of joint region where we have an area that looks a little bit more normal over on the left side, and then we have the abnormal region on the right side. So what's lacking in the right side?
I'm not seeing like good tubules.
Yay, perfect. Okay, so
Like, where y'all at?
yeah, where'd you go? So
I mean, I see
all
what
of these...
replaced it.
Okay, good. Yeah. So we see there's matrix here. We see there's tissue here. But really, honestly, these tubular profiles, and it's probably a little bit easier to pick up on the PAS. I like the other core a little bit better. Let's go. Get this core like a little better. Or part of the wedge. So we have these tubules here. And hopefully you guys can see that they are let's see, get this bigger. So we have the tubular basement membrane. We have these good epithelial cells. They've got great round nuclei. They even have a prominent brush border. So this is actually, this particular proximal tubule is pretty darn healthy. This guy's probably a small underdeveloped or immature glomerulus that never developed over here. But all the tubules in this area look pretty good. You know, we're going to take a little bit of artifact away. Like these guys are probably a little stressed or squished. But then if we go to this other region here, we have a whole bunch of matrix and no tubules. And so All that matrix, if I want to go to where, oh, it's because this is going to make me, hold on. I'm going to minimize this for a second. I know. And then I'm going to, I don't know how to get this little bar to go away. Oh, there we go. That's the window. Okay. So, the trichrome stain is called a trichrome, even though in general we usually only focus on 2 of the tri. So the important things that we study or we assess with a trichrome stain is the collagen, the amount of collagen, and also the red is going to be usually our cell cytoplasm is going to stain red. The nuclei are supposed to be kind of a dark black red, so that's why the trichrome gets there. But if we go back to our area of interest, we see pretty healthy tubules over here. They have a little bit more matrix in between them than we're used to, but this other region is basically all collagen and very few tubular profiles. And so, and the collagen itself also doesn't really have a lot of inflammation in it. So, and this has always been a supposition for me. It hasn't ever really been easy for me to prove that I'm speaking the truth. But my truth is that because these are really uninflamed regions and it's just very dense collagen, that I suppose that it's kind of always been there. And it wasn't a post-inflammatory collagenous deposition, that this collagen was just there and the tubules never really got to that area. And we can even see the little sclerotic glomeruli themselves are mostly collagen. They just have a few nuclei hanging out. So when you have the very atrophic sclerotic glomeruli, they're just basically huge meshworks of collagen. So those are the features that I often see with this type of disease. And then the fact that it's multifocal is also very supporting for what type of lesion we think it is. There are regions in the other part of the sample that have collagen deposition, but you can see, hey, there were previous tubules in here and now they're just atrophic. So we do have a mixture of what's happening of having just huge regions of collagen and then regions that have collagen and atrophic tubules, and then regions of normal tubules. And so that is, in my mind, in my truth, is indicative of progressive scarring. So we already had a maldeveloped kidney because we had regions that had collagen without any tubules, and it really did not look like it was post-inflammatory collagen. We already know this kidney is also going to be more stressed than usual because it's the only functioning kidney. And so it has a higher demand for filtration than without it. And so now we're seeing this kind of advanced progression of even the regions that had developed are stressed and overworked, and they're undergoing glomerulosclerosis, this glomerular dilation with the cystic atrophy, so the Bowman's capsule cystic atrophy, and then the atrophy of their associated tubules. Yeah.
Hey, Rachel.
Yeah.
It's funny. We were actually just talking about renal malformation with our residents this past week. When it comes to primitive mesenchyme versus fibrous connective tissue, it was a struggle for how to delineate between the two. I feel like I just look for more immature collagen / like a little bit more of like a stellate appearance, almost like what I see with like an epulus. And then I also do a special stain that I can reveal or not reveal if you want to know, or if you want me to share it or not.
What
so kind of confirm too. But I just want to get your opinion as far as like helping people delineate between, is it just fibrous connective tissue or is it primitive mesenchyme?
Yeah, so the original paperwork or original reported papers in like the 90s or early 2000s, I think, maybe late 90s, was that primitive mesenchyme was the diagnostic criteria, and it had a picture, and we have been reading biopsies from dogs and some cats since technically 2006. And when we were doing the WSAVA categorization and scoring paper, what we realized is that all 8 of us pathologists had different perceptions of what primitive mesenchyme was. And we had one meeting where we just argued with each other. I am like you, Sarah, which is probably why you believe that they should have a more stellate appearance to the cells. They shouldn't look like just it shouldn't be very like bands and bands of collagen and tiny, tiny little fibroblasts. It should be a little more haphazard with almost like a stellate appearance to the cells themselves. That's what I've always called. It's a little bit more loose as well. It's not as dense collagen, but there were people that adamantly disagreed and said that that was not what primitive mesenchyme was. So based on that, when we wrote our atlas, we just said, hey, it's mentioned, but we don't really even know what we would call primitive mesenchyme. So we don't think it should be a requirement for the diagnosis. What stain are you guys talking about?
Alcyon blue.
Oh, okay. Oh, does it stain it pretty well, like the haziness?
Because the primitive mesenchyme should have a more mucinous component than.
Yeah, you should. Like some people recommend it to. Again, the primitive mesenchyme technically is going to be more medullary. Oftentimes it doesn't have to be, but you kind of have to have, if you're really thinking you've ruled it in or ruled it out, is making sure you have like almost like a cross section of kidney. But yeah, that's a good idea. We haven't ever done that with our cases, so it would be interesting.
Yeah, I was just curious on your, because I think I had been reading enough or reading more about it just because it got brought up at rounds, and I was like, I agree, it's really hard, and I kind of struggle, and I look for it to be less mature, which is hard to define.
And I think that's probably part of the reason that you and I have that agreement is because we obviously co-instruct each other. But yeah, I remember that meeting, and I remember us basically being like, we can't use that as a criteria for diagnosis if even the people that are scoring this for our own categorization study don't agree with what it is. And the other feature in the PICUT or PICUT, I'm not sure how you say their name, that original paper was looking at evidence of osteoid or chondroid matrix in the kidney. It is one of the common features of renal maldevelopment / renal dysplasia in humans. It is incredibly rare in small animals. I usually see osseous metaplasia more associated with tumor development in dog and cat kidneys than I do for renal quote unquote maldevelopment dysplasia. So even that feature, which is kind of mentioned, and in the paper, she's like, oh, it doesn't really, you don't see it that often. I think they have like 1 or 2 cases out of their 70 dogs. So you should, the comment of, oh, we don't see it that often. But we just basically said, if you see it, wow, that's amazing, but you're probably never going to see it. So what we have in our atlas is presence of fetal / immature glomeruli. I try to count them and give a percentage. I don't know what the percentage means. It doesn't really, for myself, have any kind of like, as soon as you get to 20%, you're wrong. Obviously keeping an age of the animal, we don't normally get biopsies from puppies in their neonatal period. But if it were a dog that died and it was only 2 weeks old, you should have a lot of the fetal or immature glomeruli. So if you had an autopsy specimen, that would be possible. I talk about having absence or paucity of tubules. I talk about the presence of dense collagen that lacks inflammation. And then I talk about the kind of multifocal pattern through the kidney. And as we kind of get close to wrapping up here, and I guess I did a pretty okay job, even though I'm not a clinician, kind of describing the case. I'm a little proud of myself. So to wrap up this particular patient, as soon as I got the specimen, I had it even on H&E and PAS. I was like, well, it fits with the fact that we have a history of something already went wrong with the urinary tract development to not form an entire kidney. So we already know that there's predisposition for this kidney and urinary tract to be abnormal. And then to see the presence of features of renal maldevelopment in the right kidney, and then also to see ongoing advanced scarring in the portions that did have tubules. So some regions that do have tubules are already undergoing atrophy and glomerulocystic change. So I do, when I see these cases, I immediately reach out to the clinician as soon as I can, just to let them know, like, hey, it's probably not going to be solvable. And I doubt the immunohistochemistry, sorry, the immunofluorescence and the electron microscopy are going to be that useful for your therapeutic choices. And so some clinicians still say, you know, the owners really want to help advance the field, or, you know, they've already paid for the biopsy, the insurance is already covering the biopsy, or they really just want to do everything they can. Because I have had, very rarely, but I've had at least 2 cases where the lesion was fairly straightforward renal maldevelopment, and the poor dog with renal maldevelopment also got an ICGN on top of that. And so there were 2 different lesions, 2 different patterns in the single biopsy. So I think that sometimes owners just want to make sure, like, hopefully, what if there was something else we could possibly treat in this kidney? And they will go forward and do the other additional diagnostics. And this particular case did that. So let's see. I'm going to stop. I don't want to. I'm not going to. You guys don't look at my screen. My screen's a little crazy right now. But I'm going to bring up the EMs and stuff, because they did everything, which was very nice of them. And they also did an SDS page, I think, for this HOCAMP.
I had a quick question for you, Dr. C.
Yeah.
Going back to the focal conversation, it's 50% of the whole kidney, or is it 50% of the section?
Of the sample that you have available. It's of the, yeah. So yeah, if you had the whole kidney, or you had a slice of the kidney, that would be, you count a lot of them to get to that. So it's usually, it's 50% of the biopsy sample. So let's say you only had 10 glomeruli to look at. If 5 of them are affected, or 6 of them are affected, it's now a diffuse specimen or a diffuse lesion. If only 3 of them were affected out of 10, then it's technically a focal lesion. Okay, so it looks like we had pretty basic non-specific labeling with immunofluorescence. And I'm just going to make this a little bit bigger for everybody. I know Dr. HOCAMP and I like to look and see what everybody has as like little tabs on their screen. I think I have everything is appropriate. I don't have anything inappropriate as the tabs of things I was scoping or I was looking at. Okay, these are photos. Okay, so here we have some EM, and this we were not really expecting to see much, and that's kind of what ended up happening. But this particular picture is kind of fun because it really does show you that wrinkling. Remember when Dr. Lynn and I were looking really close at the glomerulocystic atrophy, and we were saying that, you know, the tops look like it's kind of like squished together. This wrinkling is one of the ultrastructural features that you can see when it's, you know, kind of squished together. And this is even a better or more kind of lower mag view of that. So see, this would be what we would normally want to see for our GBM, a fairly smooth contour line. And then we get to this jumbled area that's all squished together. It does look like there's a few too many cells, but again, it's probably because everything is shrunken down into this tiny little ball. Here we have our podocytes. And they even have evidence of hypertrophy. So their nuclei are quite prominent. They are kind of extending out into to urinary space. I don't really see very good foot processes in many of these areas, and it gets a little jumbled again because everything's squished together. So if we're looking at this little part of a capillary tuft, you don't see really good foot processes, not really good foot processes over here. These little nubbins here, these tiny little, make it a little bit bigger. These tiny little things, that these little like extensions, they almost they do resemble the size and the shape of foot processes, but you can see they're not actually going to a GBM at all. And so what this lesion is called microvillus transformation. So actually you can see they're extending from a podocyte. Here's podocyte cytoplasm, and there's these little tendrils that are going out from the podocyte cytoplasm. Again, I make stories up so that everything has a purpose in life. And my story for this is that podocytes are unhappy with their lot in life, and they are not able to maintain their normal foot processes. So they start to activate actin filaments all over their cell body, and then that makes those little villus extensions. Don't quote that for anything published, but to me it makes sense is that they're not able to maintain their actual foot processes towards the GBM. So one of the reactivity processes is to make extensions kind of throughout their cell body, and that's why they kind of go all over the place. Here we do have a few good intact foot processes. So there are some podocytes that are still doing their job, but in general, a lot of them are basically pavemented along the GBM. And again, you can clearly see more of these little microvillus extensions. These are just going from between one podocyte to the next. They're not going anywhere near the little wrinkled base membrane. So that fit with what we expected. We did not see any evidence of electron-dense deposits in the capillaries. And so we just saw kind of all these wrinkled GBMs, upset podocytes. Oh, here's a great podocyte. So he's basically attached to this part of the glomerular capillary. And then there's foot process effacement all along this little wrinkled version. He even has a big space in between his cell body and what's going on deeper to him. It almost looks like an evil mouth if we rotated it a little bit. So that podocyte, again, is making these little extensions outwards from its cell body and not towards the glomerular base membrane. These are such pretty EMs. Okay, I think we have a little bit of IF, maybe not. Let's see. I might have just scored it and not put pictures. Oh, here's the IF. So the IF, remember that what we are interested in is looking for immunoglobulins that are indicative of something that would form an immune complex. So as everybody's eyes is drawn to the IgM, almost always we see a degree of staining whenever we look at an IgM immunofluorescence, especially in dogs. IgM is a very big molecule, and the antibody that we are using, the FITC labeled antibody we are using to label the IgM is going to basically pick it up in a lot of places. So we also kind of wonder, is everything just a little sticky in this area? And that's why we're seeing the little bits of staining in the mesangium. So IgM is good for us to say this is kind of background for what we're going to see for any kind of even healthy kidney. We're just going to see some degree of staining with IgM. But what we're interested in is looking to see the comparative amount of staining of IgG in comparison to the IgM. You can see everything is basically staining with the IgG. There's a lot of background staining with this particular stain. And so we're not trusting that anything that's going on in the glomerulus is really staining at a greater intensity or more granularity than what's going on in the interstitium. IgA is completely negative. And then lambda light chain is, again, it's actually matching the IgM, which makes sense because there is lambda light chain in the IgM molecule. And then the C3, which I don't know I guess it's down there. So the C3 is going to tell us, is complement actually activated in this glomerulus? And you have very minimal DIT dot staining. So the complement doesn't seem to be significantly activated. So the immunofluorescence was fairly non-specific, and you always have to kind of interpret the staining pattern, the granularity, which is important, with respect to what is non-specifically labeling in the same slide. So C3 always labels the tubular base membranes for some reason. And that's actually quite strong, and you can see very minimal staining in the actual glomerular tuft. So we were able to diagnose renal maldevelopment. What was my bottom line for the biopsy? Well, let me make it bigger, make it smaller, I mean. I said renal maldevelopment characterized by 30% fetal immature glomeruli and then regional paucity of tubules. I probably could have elaborated a little bit on the fact that now there's advanced scarring in one region, which is probably secondary to the higher workload. I commented on that in the comments, but I probably could have put it in the actual diagnostic line as well. And thankfully she was spayed, so she's not going to be making puppies, which is good. Also, I don't want this dog to be pregnant because that's going to put a lot of stress on her kidneys. So, or on her kidney, I guess I should say. So, thankfully they went ahead and made the right decision to spay this dog. And I think she's actually doing okay. I know we only have like 4 minutes left. But I will say that a lot of times when we get these kinds of cases that are young dogs, they've never known a life without having some degree of azotemia. So they basically, like, since puppyhood have had mild azotemia. I mean, this is just a generalization. This isn't a fact, but you know, if you think about having gone through puppyhood with some mild degree of azotemia, they often are not that sick by the time they get biopsied. So clinically, sometimes the only feature that we're worried something's wrong is maybe isostenuria on their urine sediment analysis, maybe some degree of azotemia. And if they're azotemic, they're not acting like it. They're not acting like a uremic dog because they never really had a great time of like being a normal serum creatinine level. They never chugged along with that normal serum creatinine. And they've always just kind of had this like weird level of elevated creatinine. And so we are currently having a case right now with our colleagues at Tufts that basically dog is acting completely normal, but again, he's already a stage 3, IRIS stage 3 CKD. He's a very young dog, and he definitely has evidence of renal scarring and maldevelopment on his kidney biopsy. And so, but he, you know, he's just feeling great. So they'll just keep him going until he starts to feel sick. And then I think that's kind of my summary of how these dogs seem to be clinically. I don't know if the clinicians here, like Steph or Amanda, have more comments about young dogs with renal maldevelopment and how they seem to be acting and behaving, or how you manage them.
I've had a pretty wide variety of cases. I have a boxer right now whose creatinine is like 1.5 and has been pretty static there for the last year. But I have a couple of dogs that in like 6 months went from like 1 to 4 or 5 on their creatinine. So I just tell every owner, you have to see how they do.
Yeah, I think usually when we kind of send out those reports, we basically say at this point, preservation of any nephron that they have is the most important like goal. And so prevention, like no possibility of exposures to nephrotoxins, no possibility of like an anesthetic event that's going to make them, hypovolemic, like all of those things of just making sure that, these are the nephrons. It's got limited nephrons now. Renal diet, making sure it's not hypertensive, making sure this dog doesn't become obese, all of those things that we are known stressors to the kidneys, just do your best to avoid. Dr. Inman, do you have another question or another comment about cases you have like this?
I was just going to say my experience has been pretty much the same. I've had several that coast along for a number of years and do fine, and then others within just a few months crash and burn.
Yeah, and it would be amazing to find that biomarker, right? Like, let's find the biomarker for plateau, and let's find the biomarker that is going to suggest non-plateau behavior. So, and that would be amazing if we could make sure that it actually is verifiable for every disease type, because it might be verifiable for some diseases, but maybe when we come to this disease, it's not as broad spectrum, I guess. Any other questions? Again, I apologize that I had to be the only person talking because I don't enjoy doing that. Dr. Hokamp, you did have a thing. I think your SDS page was typical for what we see in these patients. It wasn't anything like earth-shattering, correct?
Yeah, sorry, I've got like
It's safe.
thank you. It was sort of that nondescript, mild glomerular tubular. What do I do with this? Oh, I look at it and we're thinking renal maldevelopment. Okay, cool. But nothing that I can go crazy with in terms of marked severity or anything like that.
Okay. And so like that'd be like great too to make sure we can have follow up and we don't need tissue. I mean, otherwise, if the dog eventually does, progress and needs to be euthanized, we always are interested in having additional tissue from the post euthanasia span. Yeah, that would be amazing if we could have that. But But also being able to follow with SDS page to make sure, I mean, eventually more and more of those glomeruli will become sclerotic and the proteinuria will probably start to bump up. But we already know the cause for that. We know it's not, it's unlikely to be a second hit with the ICGN unless you're one of those really rare 2 cases that I've seen before. So.
Yeah, the SDS pages are oftentimes interesting on these because, and one of the things I usually put in the comments is that a lot of times the SDS page like under estimates the amount of severity that you would potentially see on biopsy. And again, because I think we're just not having that degree of proteinuria.
Yeah.
Because those things aren't doing their job.
Okay, so we will end now because we're a minute over. Thank you guys for putting up with my voice for that long. And let me just, as we're doing this, Tuesday, I am not going to be doing rounds on Tuesday in September. So I think we'll reconvene in October. I'll double check with Dr. Shropshire. I know the patient she wanted to discuss was a euthanasia case anyway, so it's not like there's an immediacy for her discussion. So I will check with her and see if she's available in October. And I will go ahead and send a quick email out to everybody saying that there's not going to be any rounds in September. But that we will try our best to reconvene in October. It would be October 15th, the Ides of October, I guess. And we'll try to get rounds scheduled for that. Okay. Thanks, guys.